Good morning, everyone, and welcome to the 2021 Annual Ori Rotstein Lectureship in Translational Research. This lectureship was established in 2011 to mark Dr. Rotstein's amazing 25-year engagement with the IMS, and it highlights achievements by renowned clinician scientists who epitomize the essence of translational research by directly impacting patient health. This lecture is an important part of the IMS academic year and a wonderful introduction to translational research for our incoming students. Dr. Rotstein is an IMS alumnus and a long-standing faculty member who was the director of the Institute between 2000 and 2010. He's currently the Vice President of Research and Innovation at Unity Health Toronto and Professor and Associate Chair in the Department of Surgery at U of T. We're lucky that Dr. Rotstein generously continues to return to host this annual lecture each year, providing an opportunity for our graduate students to meet him, and we look forward to hearing from him later this morning as he facilitates the panel discussion. So sit back and enjoy the exciting 11th annual lecture and get ready to listen to and engage with our panelists afterwards as they discuss their journeys through research. Thank you.
Perfect. Thank you, Dr. Osborne. That was wonderful. Next, we're going to be showing you a quick video to introduce our keynote lecture. This is new. We didn't do this last year, something we've always wanted to try out. So this video gives us an insight on our keynote's personal hobbies as well as endeavors outside of her career in academia. So everyone sit back and I hope you enjoy this keynote video.
Travel. I love to travel. I love to explore new parts of the world, see new cultures, see how people live. Chocolate. Chocoholic. A few years ago, it was Santana, Smooth. It was like, I could have listened to that 24/7 for a week. I would make everybody get along. I would like people to be nice to each other and collaborate. If people work together and collaborate, you can move forward much faster. Life is much better and much easier. So I have a magic wand. I'll make everybody get along. Probably Mary Robinson. She was the past president of Ireland, and she now chairs a group of people that are called the Elders. And the Elders was the organization that was set up by Nelson Mandela a couple of decades ago. And this was a group of world leaders who were no longer world leaders. They were retired or passed, and therefore to comment on important global issues. I find them very motivating. There's a very interesting book you may want to look at. It's called Turn the World Upside Down. I think it's Sir Nigel Crisp in the UK. It was written some time ago. And it's basically about, you know, learning from the ones that don't have. We're sort of in the West and the North stuck in our ways, and you know, since necessity is mother of all inventions, you know, there's probably going to be a lot of helpful, practical inventions coming from Africa and Southeast Asia if we could just harness that. I grew up actually in Poland, and I moved here to Canada during university, and my main motivation in life was to get a job and be employed. But I was very flexible, so I was prepared to do in medicine what needed to be done rather than, you know, having some preconceived idea. My best memory is interacting with a very famous oncologist in Toronto, Vera Peters. When I started at Princess Margaret, she was just about to retire, and we had discussions about, what makes you a scientist and researchers, and what motivates you? Curiosity. You have to have curiosity to explore something new, to, you know, connect the dots and do something. And she thought that you don't have to be brilliant, but you do have to be curious. You can leapfrog, and if you only sort of think of how things can be done, rather than look at all the barriers. You know, I saw a beautiful innovation about, they couldn't have ambulances because there were no roads. So they invented an ambulance on motorcycle. So the motorcycle with a bed attached. And what you did is you actually fulfilled what you needed to do, which is transport a very ill person to the health center quickly, right? I always sometimes put on slide a quote from actually Marie Curie, who sort of said, I never think of what has been done. I always think of what still needs to be done. And I think I get more, you know, interested and excited about potential for the future rather than, you know, analyzing the past. We live in the globalized world. And you know, if everybody contributed a little bit and we learned from each other, we would make progress much faster.
We will now commence the 11th Annual Ori Rotstein Lecture in Translational Research. And with that, I would like to invite Dr. Marianne Korczynski to introduce the keynote speaker.
Thank you, Zoya, and good morning, everyone. I am Marianne Korczynski. I'm a senior scientist at Princess Margaret Cancer Center, associate professor at University of Toronto, and course director for MSc 1010-1011. And on behalf of everyone at the IMS, I'm really delighted to introduce today's invited keynote speaker, Dr. Mary Gospodarowicz. Dr. Gospodarowicz is a professor of radiation oncology at the University of Toronto. She's the past chair of the Department of Radiation Oncology and past medical director of Princess Margaret Cancer Center. Her research interests included clinical trials evaluating radiotherapy in lymphomas and GU cancers, image-guided precision radiotherapy, and cancer survivorship. Her current interests include staging and prognosis in cancer, global cancer control, quality cancer care, and mentorship. And I can personally speak to the latter, as I myself was an early career investigator when she was chair of my department. Dr. Gospodarowicz is really a true leader and mentor that promotes the growth and development in others by challenge, by support, and by being the best example. I still remember our conversation 10 years ago when she looked at me and she said, "We must get you an IMS appointment." So she did, of course, and here we are. But Dr. Gospodarowicz's vision and impact reaches far beyond our departments and our borders. She's a past president of the Union for International Cancer Control. She participated in the Harvard-led Global Task Force on Cancer Care and Control, the Lancet Commission on Global Access to Pain Control and Palliative Care, the Lancet Oncology Commission on Expanding Global Access to Radiotherapy. She's a member of the board of directors of the City Cancer Challenge Foundation and currently co-chairs the Lancet Commission on Cancer and Health Systems. It's my great pleasure to welcome this year's keynote lecturer, Dr. Mary Gospodarowicz, and the virtual floor is yours.
Thank you very much, Marianne, and thank you to the students who invited me. It's always a very coveted invitations by students to give an honor of named lecture. Let me share my screen and I'll begin. Can you see my slides?
Yes, we can.
Yes.
Great. So I have nothing to disclose, unfortunately. In this lecture, what I like to do is consider the following subjects. As you can see, I have lots to cover, so hopefully we'll finish on time. First of all, what do we know about the cancer burden globally? This year, close to 20 million people globally will be diagnosed with cancer. And unfortunately, this number is projected to go up by 50% to 30 million in just next 20 years. And while there is going to be increase in number of cases in Europe and North America, proportionately, you can see that it will be much greater increased cancer burden in Asia, Africa, and Latin America, the parts of the world that are not as well equipped to deal with this burden. And cancer is now the leading cause of premature death in most of the developed world, North America, Europe, Australasia. But it's also number 2 in light blue and number 3 cause of death in the rest of the world. And when you look at the variety of cancers that we have to deal with, and this is not a histopathological diagnosis, this is just the presenting site of cancer, you can see that the 4 most common cancers account for about less than 40% of all the cancers. So there are many other cancers that occur in the world. And when you look at the cause of death, similarly, the top 4 cancers account for about 40%. And this year, we expect close to 10 million people will die of cancer. It's compared to so far in a year and a half, 5 million people died of COVID. Also, when you look at the where the cancer is observed in the world, you can see that 50% of all cancers that present, this is the incidence, happen in Asia, and almost 60% of all the deaths happen in Asia. That's where the most of the world population is. So you can see that we have a lot of information about the pattern of cancer and its incidence. But I'd just like to put it in perspective, looking at the publication called Cancer in 5 Continents, which is published by International Agency for Research on Cancer, IARC. And most of the data comes from Europe, Australia, and North America. And when you look at the paucity of cancer registries that report data to IARC in Africa and Asia and Latin America, this is actually quite startling, knowing that most of the data that we talk about is data that's derived or modeled rather than real world data. Now the situation is getting better. These are the consecutive editions of Cancers on 5 Continents, and you can see that the number of populations and registries that are covered is growing rapidly. But unfortunately, the number of countries that are covered is not growing. And you can see that the problem is with coverage in Africa, where even though the countries submit the data from registries, very few are accepted because of incompleteness and poor quality of data. So we do have a problem. Cancer is known as a very complex set of diseases. So what contributes to the complexity of cancer? First of all, the pattern of the incidence of cancer varies globally. So this is in men, the most common cancer is prostate cancer, except for Asia, where it's lung cancer, and in India, where it's lip and oral cavity cancer, and some part of the world is colorectal and liver cancer. In women, it's mostly breast cancer, it's the pink color, and cervical cancer. When you look at the mortality, you can see that it's flipped now. The lung cancer is a predominant cause of death in men, and also in many parts of the world in women, showing the improvements in managing breast cancer. But in the other parts of the world, breast cancer and cervical cancer in women still predominates. And as you can see in Africa, where the smoking rates are less, prostate cancer still predominates. In addition of geographic distribution, there's also differences in the life course of a person. So in the children, the most common presenting cancers are leukemia, lymphomas, and brain tumors. The same for mortality. In the middle of the life, it's breast cancer and cervical cancer. Later in life, it's lung cancer and prostate cancer that predominates. And as far as mortality, it is lung cancer, liver cancer, and stomach cancer. So there is this complexity of where in the world you are, what age people are, and then there's added complexity of the elements of cancer control, such as prevention, a lot of intervention, screening, many sophisticated diagnostic services that are needed, treatment, survivorship, supportive care. This is all very nice, illustrated by the National Academy of Medicine publication called Guiding Cancer Control. And we're just talking about the disease and tumor, but there's also the conflicting and complex area of individual health and population health. So when you talk about the cancer control, it is a complex adaptive system that one needs to deal with. And our ability to do something about it, our therapeutic tools are increasing. So in the first half of the 20th century, we had surgery and radiotherapy, later on cytotoxic chemotherapy towards the end of last century. Now, targeted therapy and immunotherapy provide effective tools for cancer control. And the complexity is growing. As you can see here, this is the list of new indications and drug approvals of new drugs for cancer that have occurred just in the last, just look at the last 10 years of number of new drug approvals for a great variety of cancers that we have to learn how to use and apply. So let's talk a little bit about the equity gap in cancer. In this publication from England and Wales, it has been shown that the long-term outcome, and that's a 10-year survival, has increased from about 25% to 50%. This is for overall survival for all cancers in England and Wales between 1971 and 2011. And you can see that this increase has been quite significant in some cancers, while the other cancers not as good. But overall, the cancer is, the outcomes are getting better. However, this is not seen everywhere. As you can see, in high and very high human development index countries, more than half of patients in top 3 cancers survive. When you look at the low and medium human development index countries, this is much less. So for every cancer group, as you can see, the outcomes are better in very high and high in human development index countries. This is also seen in childhood cancer. As you can see, the estimated 5-year net survival for childhood cancer is excellent in high-income countries, Europe, North America, Australia. It is less in Asia, in Latin America, and it is quite dismal in Africa. This is a highly curable cancer. And this equity gap is due to availability of care, availability of early detection, prevention, diagnostic service facilities, health professionals, and so on. But also affordability. So even when services exist, can you afford them? And awareness. So if you're not aware that cancer can be treated or cured, there's a stigma against it. And one also has to note that these equity gaps also exist in high-income countries between different populations. And there's a lot of information and data about the lack of resources. This is from Lancet Commission on Global Surgery, looking at the proportion of population without access to surgery, the dark red being areas of the world where the access is extremely poor as compared to North America, Europe, or Australia. The same can be shown for radiotherapy resources. This is a map showing the number of radiotherapy equipment per million population around the world. And you can see the access is good in North America, Europe, and Australia. It is dismal in Africa, where there are a number of countries, quite a large number of countries, without a single radiotherapy machine. And the same can be shown for availability of CT scanners around the world, with huge parts of the world with minimal access to diagnostic equipment. And this summary from World Health Organization report on cancer shows proportion of countries that reported cancer services that are generally available in the public sector. And you can see that it really varied by the income. Interestingly, the access to radiotherapy was always worse than the access to surgery or chemotherapy because of the need for capital investment. So cancer care is expensive. And do we have information? What are the benefits of investing in cancer? So now, a number of years ago, in the work of the Lancet Oncology Commission on expanding global access to radiotherapy, we were able to calculate the need for radiotherapy indications between when we studied in 2015 and 2035. We also were able to calculate the benefit in terms of local control and life saved every year. And over a period of the study, we calculated that in low and middle income countries, we were able to save 27 million life years. So huge benefit in terms of life years. Using the methodology developed for looking at the benefits of treatment of HIV/AIDS, we also calculated the return on investment in terms of growth in GDP. And regardless of whether we calculated the nominal cost of scaling up radiotherapy over 20 years or cost-efficient cost, which was higher utilization of equipment, the return on investments were positive after about 10 years in the nominal and almost immediately in cost-efficient model. And there are two benefits. One is human capital benefit, which is really return to productivity, and full income benefit, which is really considers how much the society was willing to pay for people being alive and contributing to economy. So huge benefits. And even greater benefits are seen from treatment of childhood cancer, because children, when they're cured, they can be productive for much longer period of time than adults. So you look at the global cost of treatment versus the productivity gains and the huge net benefit that can be realized in the next 30 years for scaling up treatment of childhood cancer. But the challenges are huge. So in the same commission for radiotherapy, we actually calculated that in order to give everybody unencumbered access to radiotherapy, how many new departments there would have to be in high income, middle income, and low income countries, how many new megavoltage machines, how many CT scanners, how many radiation oncologists, medical physicists, and radiation technologists would need to be trained to achieve that. And you can see the numbers are staggering. And this is in the era where the National Academy of Medicine shows that we have projected shortfall of physician in the next, even in the next 10 years, that's quite worrisome. So I like this slide because we know all this, and yet we're not changing what we're doing. And Einstein said that insanity is doing the same thing over and over again and expecting different results. So we do need innovation, and we need innovation both in health systems and in healthcare delivery. Julio Frank some time ago wrote in this Systems Thinking World Health Organization book that there are now 4 revolutions that will transform health and health systems, and they're already underway. And you know that there's a revolution in health sciences, in life sciences, that's what you study. There's a revolution in information communication technology, but there's also new focus on social justice and equity, and also in systems thinking to transcend the complexity of healthcare. And one of the concepts that's been put forward by National Academy of Medicine now 15 years ago is the concept of learning health systems. So the outcomes of learning health systems that are expected are to increase the value by improving patient experience, provider experience, population health outcomes, and dealing with rising healthcare costs. And the way to get there is to generate a lot of data, create knowledge, apply the knowledge to practice, then measure the value of this new practice. So generate new data to inform the new knowledge and have this really continuous circle of continuous improvement and change management that needs to happen at local, regional, national, and global level. And it needs to happen real time and fast. At the present time, it's too slow. And the recent article in New England Journal of Medicine suggested that to advance the learning health system, we need science, and you know all about that. We need informatics, we need right incentives, and we need the right culture, because everybody needs to support this direction. The COVID-19 pandemic, as everybody knows, caused major disruption in most systems with global reach, in healthcare, in business, in industries, everywhere. It had disproportionate impact on vulnerable population and women. But pandemic has become a new complex adaptive system that actually had some positive effects. There's been accelerated learning, accelerated action, and we all witnessed the rapid action in vaccine development, clinical trials of vaccines, guidelines and regulations for managing pandemic, and in healthcare, this explosion of virtual care that was always there but underutilized. There's been unprecedented collaboration within the health sector, but also between the sectors, between the governments and private sector and academia. And there's a new respect for health and for science as a result of the pandemic. And you can just look at this review in Nature Medicine last year that looked at the digital technologies used in COVID-19 response. And I won't go through all of them, but you can see that a number of them could be used in healthcare and applied, and we need to accelerate this adoption. And the reason for that is that we all know this graph that human cognitive capacity is limited, and with the growing complexity in healthcare and the cancer, we need help. And this is well discussed in the Institute of Medicine or National Academy of Medicine publication, Artificial Intelligence in Healthcare. And there are many, many tools. I'm just giving few examples of leveraging artificial intelligence tools in learning health systems. So whether it's for clinical decision support, patient-centered care, community links, care continuity, optimized operations, that list can go on, and it's well described there. There are issues because although AI can result in augmented intelligence, improved partnerships, much rapid turnaround for development of clinical practice guidelines, much better use of clinical evidence and scale up of rate of innovation. There's also a bias and the trust issues. And there's all this business of the hype versus hope of artificial intelligence. And we're all familiar with this Gartner's hype cycle. If something is new, it's perfect, then you have the throw of disillusionment, and then gradually we learn how to use the innovation. And there are issues. You have to pay attention to cybersecurity with AI, and the recent examples in Newfoundland just in the last 24 hours shows you how important it is. And it also one needs to realize that AI will be reshaping medicine and outside medicine. It certainly will reshape the employment and cause displacement of number of professions, and that has to be dealt with. The other thing that AI can facilitate is at the present time, we have two dichotomies. There's clinical medicine that diagnoses, treats disease, and then there's public health, and you can see it defined. But more and more, we need to integrate these two solitudes into population health that deals with health outcomes, patterns of health determinants, and policies and interventions that link them. And certainly having ability to use AI tools gives a promise to integrate these two. And just last week, the Lancet published a Lancet and Financial Times Commission on Governing Health Futures 2030 called Growing Up in a Digital World. And they conceptualized digital transformation in looking at digital infrastructure, social context and rights, governance and legal system, and looked at how we can manage the digital transformation, pointing out all its benefits and also all its downfalls. So this is, I'd like to recommend highly, because it's a different look at the digitalization, with people saying it's not really transformation, it's a transition, and we're in the middle of that. And we can either slow it down or embrace it. Now, to end, I'd like to talk a little bit about the engagement and about leadership. So WHO Constitution, for now more than 70 years, enshrined that the highest attainable standard of health as being fundamental right of every human being. It's an old statement, but I would submit it's still in development. And the right to health includes access to timely, acceptable, and affordable healthcare of appropriate quality. So it means comprehensive suite of healthcare. And the major direction of World Health Organization right now is scaling up universal health coverage. What it means is that all individuals receive health services they need without suffering financial hardship. But UHC means more. It means to reframe and to decide not only what services are covered, but also how are they funded, managed, delivered, how they're integrated, how the focus is on needs of people and communities, what are the most appropriate setting of providing care, and how to coordinate, provide seamless care. And the idea is to reduce out-of-pocket expenditure and increase the population covered and increase the number of services covered. I don't think there are many countries in the world where everything is covered for everybody all the time, but scaling up is a direction where most countries are going right now. Another concept that I'd like you to think about is the concept of global public goods. The healthy society needs global public goods. They are peace, security, fundamental rules of behavior, regulations, knowledge. And the global public goods are defined as non-rival, which means that if one person consumes this good, it doesn't diminish the goods being available to others. And then if I use it, I cannot prevent somebody else from using it. So if I use peace, security, and knowledge, it's available to everybody. And the global public goods for cancer are the knowledge and technologies. And if we produce more global public goods, we can accelerate the progress in cancer, but also policy and regulatory regimes and health systems are the key global goods that we can contribute to producing. I have shown you that we know a lot about cancer. We have a lot of data. We know about burden. We know about the fact that we can that we're making progress. We know that it's fiscally a good idea to scale up services, but the progress is slow. So what is needed, as you've seen with pandemic, is the knowledge and data in science is not enough. You need advocacy. And advocacy needs to be evidence-based. So one needs to document the need, the shortage, and offer solution. But we also need to influence the political machinery globally. And we need to use civil society and do advocacy on the local level, country level, and also global level. So generally, we need research to generate the evidence needed. We need evidence to inform the advocacy, but we need advocacy to change the policy to result in change. And there are now multiple actors in cancer control. So there are governments. Governments are needed. You've seen it during the pandemics. The good governments can reduce the number of casualties from pandemic. The poor governments may actually put their populations at risk. There are many international agencies. World Health Organization is not the only one. There are UN agencies, there are non-governmental agencies. There are many actors in this area. There's academia, there's universities, there are professional associations, there are philanthropic institutions, research funders that make a huge difference, and there's private sector and industry, and all of them need to work together in order to accelerate the progress. And for that, we need to scale up the leadership. We often think of leadership as something that people do when they get older, when they assume positions of responsibility. However, if we can move the leadership agenda towards the younger people, younger population, beginning of your careers, and have leadership training and leadership competencies, how much more, how much faster we could create progress. And there is a National Center for Healthcare Leadership that actually developed health leadership competency models, looking at all the action domains and enabling domains that you need to sort of learn and be exposed to in order to become a better leader faster. So leadership education and leadership development is an essential part of generating progress in cancer and in healthcare. And what is needed is a T-shaped people. I don't know whether you're familiar with this concept. People in HR are familiar with it. So in IMS and in University of Toronto, we create the I-shaped people. We create people with depth of expertise. The more you know, the more you're expert, the better. However, in order to make progress, you also need to be able to work cross-discipline, work in teams, look outside of your area of deep expertise, and be able to connect the dots and connect the concepts that are developed elsewhere so you can actually use your expertise, and that results into the desirable future full of T-shaped people. So cancer, healthcare and cancer are complex adaptive systems. That's been actually quite accepted everywhere. And many people are trying to simplify them. But as Adam Grant says, that while we strive for simplicity, we must actually respect complexity, because otherwise you can develop ignorant simplicity, which will be actually detrimental. So we can embrace new technologies and new progress to bury the complexity with the ultimate goal that we'll develop elegant simplicity, so informed simplicity. What I tried to convey to you in the last half hour or so is that cancer is a major global health problem. And for an individual patient, we're making huge progress. Survival is improving, age-related mortality is actually decreasing, especially in high-income countries. There are new treatments, lower toxicities, better support. It looks better. But for populations of phages, challenges remain. The system is quite complex. There's increasing cost. There are still issues in access, and you're probably familiar, there's issues in access in our country. The issues of access are huge in low-income countries. And there's also a problem in maintaining high quality, because the poor quality actually results in harm and results in increased cost. So progress has been slow in creating equitable access in many parts of the world. But we, to a certain extent, have accepted that the progress in healthcare has to be slow. But the COVID-19 pandemic has shown that we can move much, much faster. I think people woke up to the fact that clinical trials don't have to take years to start up, that progress can be much faster. So with that, I'd like to end. I'd like to acknowledge a huge number of people that really influenced my thinking in the area, of whom I worked both in Toronto and internationally, and my younger colleagues who continue to make me think and challenge my concepts. Thank you very much.